It's when you feel like what you're doing doesn't make a difference. You can't spend the time with your patients that you want, or it doesn't matter, they die anyway. Whatever it is, I think this loss of meaning in medicine is a really important factor that's worth looking at more. There are also challenges in institutional culture. Clearly, the hospital administration has a little bit of a different goal than the resident day-to-day life. And there's a little bit of this perceived lack of support, a lack of professionalism, and a disengaged leadership that, again, doesn't necessarily contribute to the resident feeling as supported as they could. And there are issues with work-life balance because for most residents, it's work and only a little bit of life. Glenn Gabbard also, in 1985, wondered whether the characteristics that we have that drive us or interest us in becoming physicians also might make us a little bit vulnerable to burnout and to depression. We tend to be a high-achieving, perfectionistic, compulsive group. And this triad of compulsiveness, as he says, might actually put us a bit at risk. Some ways our traits are very adaptive. By being compulsive and perfectionistic, we aim for diagnostic rigor. We don't let things fall through. We are thorough. We are committed to our patients. We want to stay current with the literature so that we're providing the best care that we can. And we are aware of the responsibility and the trust that our patients are putting in us to take care of them and to help them. But there are ways in which our personalities might actually get the better of us. We have a tough time relaxing. We don't often take vacation in quite the same way. Of course, during internship and residency, you're simply told when you're taking vacation, which might not maximize your ability to use it. We sometimes have a sense of not doing enough. There's more. We always have to be busy. We always have to do more. We might take on more things than we are actually able to do. We have difficulty setting limits. Oh, there's one more admission, and it's 5 to 6, and I'm supposed to leave at 6 o'clock. Okay, I'll do it. We confuse selfishness versus healthy self-interest. And as I mentioned, we have difficulty, some of us have difficulty taking time off. So there's burnout that we're vulnerable to, and there's depression that we're vulnerable to. Burnout is not the only problem, and as I mentioned before, the relationship between burnout and depression is unclear, but it appears that they are distinct syndromes that require different interventions. We can talk a little bit more about that later, although for now, nobody's interested in doing a trial of Prozac for burnout. So there's something different about them. Well, nobody except for me. There is symptom overlap between burnout, and the conditions are highly, highly correlated. But let's talk about depression. What do we know about depression during internship? Srijan Sen, who is a psychiatrist at the University of Michigan and did a sub-I on PI5 when it was the eating disorder unit some time ago. So I'd like to say we influenced him a bit away from eating disorder research. He was interested in studying genetic contributions to depression, actually, and he was looking for a situation that was stressful so that genetic vulnerabilities to depression might manifest themselves. And he accurately remembered that internship is kind of stressful, so he started a study where he sent out a series of questionnaires at 4 time points across the year. He used a PHQ-9 to assess for depression, as well as a number of other metrics to evaluate for other things. And he's been doing this, actually, this intern health study now since at least 2010, since before that, actually. And what he found is that before internship, so this is sort of April, May, June, post-medical school graduation, but before internship, the percent of interns with PHQ-9 levels of depression, he uses a cutoff score of 10, is very low. It's about just under 4%, okay? But within the first 3 months of internship, those who have a score on the PHQ-9 above 10, so would meet for depression, would screen positive for depression, that number goes up to about 25 to 27%, and it stays there. These are not necessarily the same people that stay depressed throughout the year. Some get depressed, some get better, some get worse, but basically the levels rise and then they stay there. So that about just under a third or a quarter to a third of interns would meet criteria for depression. Some know it, and some don't. Okay, but maybe it doesn't matter. But the truth is, depression results in, depressed residents are actually making more medical errors than non-depressed residents, and actually making an error, a medical error, actually may also cause depression. In this study, there was a direct association between the number of hours worked and the risk of depression, but there was no evidence that your depressive symptom before starting internship was predictive of developing depression during internship. Another study that came from the intern health study that really I find interesting was they asked at the end of internship, they did a qualitative study, and they asked interns, what factors made this year difficult for you? What factors made this year easier for you? What was your most memorable experience, good or bad, as an intern? And how do you feel the experience of internship has changed you? I don't know how many of you are all thinking back to your internship and are answering those questions to yourself. I'm probably sure you remember. But here's what they found. When they looked at the responses of interns who at some point during the year had met for depression, that's a PHQ-9 score above 10, they were more likely to say things like, I needed to reevaluate or regret my decision to become a doctor. They were more cynical. They'd reported losing their sense of self. They were more frustrated with the bureaucracy, with the paperwork and things like that. Let me read you some of the quotes from their paper. I am more unsure about my career now than I was when I started, and I'm not certain I want to be a doctor anymore, which is really sad since I've worked so incredibly hard towards this goal. Or, I have never doubted my decision to go into medicine as much as I do now. I am not a better person. I am more one-dimensional than ever before. I am less me. Or whether it was a difficult case medically or emotionally, there were a lot of frustrations involved in providing good patient care. There were roadblocks, there was paperwork, there was bureaucracy. And those were what the negative interns were more likely to say. In contrast to the non-depressed interns, were more likely to say things like, I actually expected to be more scarred by this experience than I have been. Most of the ways in which I have changed have been for the better. I am now more competent, more efficient, more knowledgeable, and more confident in my role as a physician. Or, I have an amazing support network of people who stand by me through thick and thin, both medical and non-medical. I do not know what I would have done without them. So, at some level, depressed people see the world through a negative valence, so maybe this isn't so surprising. But these interns didn't necessarily know that they were depressed, and they were considering leaving medicine because they thought the experience was not what they had expected and not what they wanted, and considered other careers. Turns out they just needed treatment. And that, to me, is why this is why it struck me. We have people who may not even make it into mental health treatment who leave medicine because they're depressed and for something that we could actually help them with. Okay, let's move to happier topics. Suicide. We have known for a while, this is actually from 2003, that suicide is more common in physicians than in the general population. This is the mortality ratio. Physicians die by suicide at a rate higher than what would be expected. 400 US physicians take their own lives every year. We've known this, but we're talking about it much more. Why might it be? What are some of the contributors? Well, as we mentioned a little bit before, in surveys of students, of house staff, and of faculty, 10 to 12% report suicidal ideation. That seems like a lot to me. And of those, however, 25% of those endorsing current suicidal ideation, only 25% are taking an antidepressant medicine, and only 16% are receiving psychotherapy. So we have interns and residents and faculty walking around with suicidal ideation, and very few are in treatment. Alcohol misuse is a common response to unmanageable stress. You can recall back as to how much you drank during internship. I will not tell you how much I did. And depression and alcohol misuse combined actually increase risk for acting on suicidal thoughts. But there's more. And there's more that I think goes unspoken. And a lot of these slides are from Maria Okendo. What also impacts us during internship is residency is when being wrong or overwhelmed or making mistakes is a novel experience. It's really hard, and you have to work really, really hard and be very, very successful to make it to medical school. Interns matching, and then to match at a fantastic program like all of those offered here at Columbia, you have to have sterling credentials, and generally, you haven't failed that much because you wouldn't have made it to where you were, okay? But there's a reluctance to report these failures, such as being unable to do your work without duty hours violations, right? So for the job of an intern is to sort of make it through their SCUT list, but now they also have a time criteria that they have to get out of the hospital. And we actually know that a number of residents will leave the hospital when they're supposed to and then go log on from home and do their work. And that may be seen as not getting their work done, as not being able to do their job. And it leads, and then you have to figure out whether you lie on your duty hours or not. And this leads to distress. And then they can start to feel like they don't really belong because people don't talk about this because it just looks like everybody else is doing fine. It looks like everybody else is getting their work done and taking care of their patients, and I'm the only one who's having a hard time because nobody wants to talk about it because they'll worry about being exposed, they'll worry about feeling or looking weak, or that no one's gonna want them to cover or take care of their patients because they can't handle things. And also for some, letting anybody know that you're not as successful and amazing as your parents think you are, you don't want to tell them that actually you're having a hard time because sometimes if your family are non-medical people, they might not even know what to tell you because they don't understand what you're going through. But for others, it's just that shame of, for the first time, not being able to excel. And it's far from actually excelling. And doctors we tend to be people who are sensitive to others and to care. We tend to want to look out for people. And often when a suicide happens or something terrible happens, we berate ourselves for not having noticed the signs of distress. And then we feel guilty about that. But some of this is most medical trainees, as I mentioned, have an enormous capacity for personal strength. And they can often compensate for the presence of psychiatric symptoms, which both makes it difficult to identify them so they can get help and ends up making them feel more isolated because we still can't read minds and we still don't know without asking a lot of the time how people feel. And isolation and the feeling of isolation is a big risk factor for suicide. And you know what, we talk about this and I'm telling you this and we're here in an educational, intellectual conversation, and then it happens at your institution, and it happened at our institution. In 2014, a week apart, an intern from Columbia and then an intern at Cornell, both in internal medicine, I believe, thought that ending their lives was the only way that they could continue. And what it did, partly because we were New York City, partly because they were a week apart, but these suicides galvanized the medical community and specifically the ACGME. What came out of this was actually a collaboration among Luba Konopasek, who was the DIO on the hospital side at the time, Christine Moutier, who's the president of the American Foundation for Suicide Prevention, and Lottie Derby, who is an internist actually at the Mayo Clinic. They put together a toolkit, right? Because we know that suicide happens, and we know that we have to address it and be ready to deal with it when it comes. And they used this toolkit last week at NYU. But it also, when a suicide happens at your institution, or maybe when it happens in New York, everyone tells you for every suicide afterwards. And so it seems like the rates of suicide among residents is skyrocketing. It happened here, it happened at NYU, it happened at Mount Sinai, and we're just one city. But remember, 400 physicians die by suicide a year. That's essentially a little more than one a day. But I don't think you're hearing about suicide one a day. I'm not minimizing this problem, but there is a little bit of, once it happens where you are more attuned to hear about it. And so another thing that the ACGME did, in addition to looking at the environment and burnout and depression and coming up with much more mental health supportive common program requirements for residents, they also took a look at, because they have the data, and they took a look at the number of deaths and the causes of deaths among residents between 2000 and 2014. And there were, in that 15-year period, there were 324 individuals who died. The leading cause of death was cancer. It was actually breast cancer in women, then suicide, and then accidents. Turns out for male residents, the leading cause of death was suicide, but when compared to age and gender matched population, the overall rates were still lower. And there was no trend, no increase or decrease trend over the 15 years. This is just the data graphed. This is the green bars, which look prettier on my screen, are the general population, and the blue are residents. But what they did with this is not to say, look, it's not a problem, we don't have to worry about this. All the rollouts that we have, we're going to roll back. Is what they said is, we have an opportunity to do better. We have an opportunity here to prevent suicides. And that's what we're trying to do. That treating burnout, treating depression, that is suicide prevention. Okay, let's shift a little bit. What are some protective factors? Resilience. Everybody is talking about resilience. Resilience is the capacity to bounce back, to withstand hardship, and to repair yourself. It's a positive adaptation in the face of stress or disruptive change. It is based on a combination of factors. It is not simply the genetics that you're born with, but resilience can be learned. And actually, at the APA, I just heard Dennis Charney, who spent much of his research career learning about resilience, mostly from a PTSD perspective and from POWs and other tragic accidents, has come up with his resilience prescription. But it's actually, it hits the highlights, and we can understand it, and we can see where psychiatrists can help. Optimism is strongly related to resilience. It is in part genetic, but it can be learned, and CBT can help us with cognitive reappraisal and cognitive flexibility to think differently about the experiences that we have. He cites having a personal moral compass as also key to resilience. For some people, that's religious beliefs. For others, it's simply a set of core beliefs that very few things can shatter. He talks about the Stockdale paradox. Stockdale was an admiral in the Navy, and I think one of the highest ranking Navy officials to actually be captured and held as a POW, who basically made it through with these two thoughts: that you need to retain your faith that you will prevail in the end, regardless of the difficulties. That's partly what we think. Great, people can sort of be optimistic in the face, but it's not to deny the traumas that you have experienced, but it is simultaneously to confront the most brutal facts of your current reality, whatever they might be. Internship and residency is stressful. It will always be stressful, because taking care of sick people when medicine can't cure everybody is stressful. But it is also knowing that it has meaning and that you will succeed, that hopefully will help people feel resilient and lower some of the rates of depression and burnout. The Stockdale paradox really defines the optimism that is most important in becoming a resilient person. That is, when you're faced with a challenge or a trauma, you look at the challenge objectively. You might make the assessment, I'm in really big trouble, but you also have to have a realistic assessment of what you're facing. On the other hand, you have the attitude and the confidence to say, I will prevail. I'm in a tough spot, but I will prevail. That is the optimism that relates to resilience. And everybody needs a TAP code. This is how POWs who were in solitary confinement for months and months and months on end communicated with each other. They had a TAP code. And according to Charney, everyone needs a TAP code. In other words, everybody needs a set of individuals in their life that they can count on, that they can share their feelings with, and that they can ask for advice in terms of facing a trauma. That is why Charney recommends you should develop a network of friends and relatives who you can share your emotions with. It also gets to combating the feeling of isolation. We're not in this alone. Medicine is actually, I'm not quite sure it's a team sport like the NCAA would think, but it's certainly a team effort. Find a resilient role model. You'll see my role models at the end when I thank people. Face your fears. Fear is normal and can be used as a guide. Develop active coping skills. Face these challenges head on rather than hope that they just wash over you or go by. And find and nurture a supportive social network and attend to your physical well-being. Exercise improves our mood, it improves our self-esteem, and sometimes you have to be creative during residency about how to get your exercise in, like you have to take the stairs when the elevator doesn't work, but that counts as exercise. And so you want to do things like that. Practicing these skills helps. It helps strengthen them and make us better. And recognize your own character strengths and use them. We all have our strengths and our vulnerabilities. Find out which ones are yours and engage them to deal with difficult and stressful situations. I'm going to call this Matt Goldman's institutional prescription because Matt and myself and Carol Bernstein, we thought about interventions. Resilience is sort of at the individual level. This is more about promoting well-being from an institutional level, okay? And we sort of came up with these 7 areas that institutions can engage in to actually promote resilience and, again, try to improve the workplace and make the lives of residents a little bit better. And this is a very, very useful and lovely slide that Matt put in to talk about the 7 areas, educating and increasing awareness, designate time for reflection, teach practical skills, build community, ensure access to care, improve the workplace environment, and transform institutional culture. And there are sort of low-hanging fruit interventions that can be done. There are sort of more mid-level and resource-requiring interventions, and there are more advanced interventions that can be put into place. And we are always thinking about how to add and elaborate and expand on this, and Matt always puts his contact info when he gives his talk, so you can talk to Matt. He's right there. Okay, let's shift a little bit gears. Burnout and depression are treatable. We know that. There is a lot that psychiatry can offer to the rest of the profession. And we know that treating burnout and depression is suicide prevention. So we can focus on burnout and depression. But even if we focus on treatment, will the residents come get it? Will they avail themselves of it? What do we know about that? Well, going back to Srijan Sen and his intern health study, what he showed us is, no, not so much. Residents don't really get treatment. This was about 15% of depressed residents sought treatment, 85% did not. 6 were in psychopharm and psychotherapy, and some were in therapy alone. But again, the vast majority, no treatment. Why not? Well, probably what you guys are all aware of, the common reasons people don't get into treatment: lack of time. Now, there is a reality to that, and there is also a resistance using piece of that. But the lack of time, doctors want to take care of themselves. I can manage it. I got it. I don't need anybody else to take care of me. Lack of convenient access. They live their lives in the hospital. And so if it's not like, across the hall, they're not going to be able to get there. And because they don't have any time, so they can't get there. Concerns regarding confidentiality. This is a big one. If I admit that I might even have a mental health concern, burnout, or depression, everybody's going to know about it. And if everybody knows about it, I'm not going to get a residence, I'm not going to get a fellowship, I'm not going to become chief, nobody's going to want me to take care of their patients, and it spirals, so nobody wants to say anything. Or they think their program director is going to go into the medical record and look up what their problems are. And they don't believe that they would be fired by going into the medical record. And the truth is, I don't either think their program director would be fired if they looked up their residents' records. There's concern about stigma, which I'll talk about in a minute, concern about cost. Even in New York City, where residents are paid more than in other parts of the country, it's still not the big bucks. And so having to pay rent and food, even if they wear scrubs every day and don't have to buy clothes, they don't have extra money, they think, to pay for treatment, especially in New York City, where there aren't that many providers that take insurance, and so it's all out of pocket. And apparently, a quarter of the residents in this study thought that treatment didn't work. Now, we can do something about that, too. Stigma is a big problem. We know in the general population that stigma exists, but it exists among medical professionals as well, and self-stigma is worse among depressed. This was a study of medical students. So a non-depressed student would say, if I were depressed, I would seek treatment. 87% said they would. But only 46% of the depressed medical students, those who actually needed treatment, said that they would seek treatment. Seeking help for depression would make me feel less intelligent as a medical student. More of them endorse that. More of the depressed medical students endorse that. If depressed, fellow students would respect my opinion less. Non-depressed didn't think so, didn't think that particularly, but depressed med students were more sure of that. Depression is a sign of personal weakness. The depressed medical students believed that more than the non-depressed, okay? Stigma is real. Stigma is also related to suicide risk, and stigma reduction can be a core component of successful suicide prevention programs. So another area where we can intervene is in stigma. And one question that I have is there's a lot of talk about burnout as a work-related syndrome, and I wonder whether it's easier to talk about burnout because there's less stigma associated with burnout than there is in talking about depression. But the truth is, we know more about how to treat depression than we do about how to treat burnout. Okay, so let me shift into the House Staff Mental Health Service. So the House Staff Mental Health Service was brought up here in 2005 and actually had existed at Cornell for about 10 years, I think, earlier than that. And then when the hospital merged, they decided to have one mental health service. And Dave Kahn saw the residents for a year, and then he decided to ask me to do it. But based on some of what we knew about what gets in the way of residents getting treatment, we designed this as a confidential, accessible, affordable, you can decide whether I provide quality care or not, service to the house staff, okay? So the process is you call me or you call Brett Rutherford. We will evaluate you at no cost to you. We are accessible in that we're here on campus, and we make our hours flexible to accommodate a resident. I've certainly stayed late to see a resident. I've yet to actually come in at 6 in the morning to see a resident, but Brett might have seen a neurosurgery resident that early or something, I'm not sure. And then we refer. And actually, we refer to mid-level or senior clinicians, because there are issues that are better handled when you have more experience when taking care of a doctor. We do have a small pool of clinicians, thank you to the Neuro 12 crew, that have offices on site. And we try to save those really for the residents, like the neurosurgery residents or the surgical subspecialties or some of the residents that really have ridiculous hours. And if they have a few minutes during the day, they need to really be able to closely and quickly access care. Initially, it was 10 sessions that were paid for by the hospital, again, to get at cost. The sessions are at no cost to them. The hospital, a very lovely person in the benefits office on 38th Street, pays the bill directly. The rate it's a reduced fee. And actually, after a while, we couldn't get anybody to take that reduced fee. So we negotiated with the hospital to increase the rate, but now residents are only eligible for 8 sessions. But that's okay. It's 8 sessions per PGY year, and then it's supposed to be insurance or self-pay after that. And at least for now, I get to decide whether we renew the benefit or we don't. And if someone really is benefiting from treatment and would take steps back if they dropped out of treatment, but they can't afford it, and the insurance that the hospital offers doesn't really have a very good out-of-network plan, I can renew the benefit. And I certainly have done that for a number of residents who've needed it. Who do we see? I'd say that the chief complaints sort of fall into 2 buckets. Half are burnout, depression, not really burnout, but depression, work-related conflicts, bad feedback from an attending or something like that. And then the other half are general life stuff. You know, my mother just got diagnosed with cancer. I am having trouble with work-life balance. I've had ADHD forever, and I need a new provider. So it's not all that it's burnout and depression. It's also it's onset of bipolar disorder that I didn't know I had. It's people that have lives and are at a time in their life when mental health stuff manifests. So that's some of what we see. Partly what I do, I just put that there to remind myself, is there is a similar program at NYU that's run by Lisa Goldfarb, who was a resident here a number of years ago, and she runs the program at NYU, and I think that Mara Ackerman, who was also a resident here, may be becoming more involved in the NYU program. And there's a program sort of similar at Mount Sinai. And so for our sake, we do a group supervision a couple times a year where we all get together, and John Barnhill, who runs the service at Cornell, and we talk about and share what the experiences are, who we're seeing, difficult cases across the city. What else do we do? Sort of how do we get the word out? How do we let people know what we do? Well, we educate. Matt said that's a good way to help for wellness. So we educate. Here I am at Grand Rounds, thank you. And I speak at house staff orientation every year. It's coming up, and I give them a little bit about burnout and depression and a little bit what to expect during internship. And I ask them all to take out their phones and to put my contact information in their phones. And I do it at orientation, and I tell them all to take out their phones so that they're not looking around to see who might actually need the number already, right? But that they're all taking it out, and so that they know that while they don't need it that day, if throughout the course of internship they might need to call me, the number's already there. And they don't have to ask, and they don't have to tell, and they don't have to reveal. They just have to pull out their phone. And since they're often on their phones anyway, no one would even notice. Okay, what else do we do? What I've done now for a few years, and they're expanding, are facilitating well-being groups. We in psychiatry call them process groups. Other departments don't like that word so much. A little bit of stigma. It's actually okay, I think. And there are well-being groups. And it's a place where residents can get together in a protected, safe space. They are regular, they are monthly, they are resident-only, facilitated by a facilitator. They are confidential. What happens in those groups stays in those groups. The program directors may hear in general, residents are okay, residents are struggling, but there's nothing specific that goes back to the program directors. The residents initiate the topics in these groups that we run, and I gotta tell you, residents are never at a loss for what to talk about. There's always something that happened that they want to talk about. When I started this for OBGYN a number of years ago, I actually took over for Linda Mullen, who also was here. She ran them for OBGYN some time ago. I said to them, you know, we can talk, I'm a psychiatrist, we can talk about medications during pregnancy, you know, I'll keep all these topics in my back pocket if we sort of run, if you guys don't have any issues to talk about, you know, we can talk about other sort of psychiatry-related things to OB. And in the, I think it's actually almost 10 years that I've been doing this, I've never had to reach for those topics in my back pocket because they have plenty to say. And it's to promote reflection on their lives and their physician-patient challenges, and to help them to at least tolerate residency a little bit better, and again, to get at the isolation and to build the community to strengthen the relationships among the residents. And Sarah Nash and Linda Golding run groups for neurology, and Sarah turned this into a poster that was accepted and she presented at the ACGME conference in Orlando. She went to Disney World a couple of months ago. So we're trying, and we're trying to develop a curriculum for these groups. And Sarah, Linda, and I actually also meet locally for supervision about once a month, once every 6 weeks. Partly because they had developed, and Linda Golding, who's a chaplain, sort of when she was asked by Neuro to run these groups, came up with a curriculum. She's like, these are residents, I gotta figure out what to do. And what's interesting is whether the groups were structured or unstructured, like the groups that I were running, the themes that come up in these groups are the same. There are common themes that residents are grappling with that we hope these groups are allowing them a space to share. Okay, house staff utilization. So we started in 2005, and as you can see, the number of calls that we get per year has steadily increased. This was the year when the suicides happened here, and we expected the calls to go up, and we wondered whether they would go up and then come down. They have not. The calls have continued to rise. There's actually about a 20% increase yearly, and that's actually a 25% increase if you look only since 2014. And in last year's numbers, we are evaluating about 14 to 15% of the residents and fellows here. That's a lot, in case you didn't know. Actually, it's a lot, but it's probably far under the number of people who really need to access it. Okay, if the rates of depression are 25 to 30%, and we're only seeing 15%, we're missing people. These are the number of sessions that are paid for by the hospital each year, and what you can see is those numbers are also going up. Interestingly, of the, each resident is eligible for 8 sessions per year. Actually, of the sessions that have been authorized, the hospital's actually only paying for about 60% of what's authorized. Now, some of that is because some residents don't need all 8 sessions. They need 1, 2, or 3. They kind of get themselves tuned up and they go back and they're on their way. Although some need more than the 8 sessions and they get 16 or more. So it sort of averages out. I haven't looked at it recently. A number of years ago, the average number of sessions that residents availed themselves of was 10. But it's also that a number, I think actually a significant portion, don't actually ever make it to the referral. And it's not because I just do such a good job at the eval that they're cured. It's more that this comes in sort of starts and stops, right? And they come because they need help, they feel a little bit better, and then they go back, and then it happens again, and then it happens again. But a number of people don't make it. Or don't make it. They don't make it to treatment. Okay. 30 departments. It's not just psychiatry that avails itself of the service. Lots of people across the medical center will call us, and a big thank you. We've referred, I added it up to 41 different clinicians. And partly one of our challenges now is as our number of sessions goes up, it's actually increasingly difficult to find clinicians to refer them to. It's a reduced fee. People are seeing residents because they want to see residents, because they're interesting, because they want to give back, because they remember what it's like. And it's reasonable, they're not going to fill their practice with residents. So we're thinking about how to address this. In terms of the top users, psych, medicine, and peds are the top 3 users of the service, with neuro and family medicine close behind. Family medicine had a little bit of an uptick when a couple of years ago the hospital fired them all by tweet and then rehired them all 24 hours later. If you want to know what it takes to get people into treatment, that was one thing. 90% of the calls are from residents. 10% of our calls are from fellows. There's probably more fellows that we could see. It's not 10% of the fellows, but most of the calls we have are from residents. Okay, we also, after 2014, we got ourselves involved in the intern health study. Partly what we were wondering was, is it worse to train in New York? This region had, data from all over the country. What's it like to train in New York? Are the rates of depression higher? And the answer is, this is the averages of the New York hospitals that were participating, which was us, so Columbia, NYP. So Columbia and Cornell and NYU were offered up their interns if they wanted to participate. And what you can see is that the average PHQ-9 score before internship is about the same for those training in New York and those across the country. And even during internship, again, while the average PHQ-9 score increases, it's not different between those who are training in New York and those who train in other parts of the country. And the percentages of those who meet criteria for depression, that's the PHQ-9 score above 10, is also not different. We might be actually a little bit less depressed when we start. We're really excited about being in New York, but that goes away pretty quickly. The intern health study also asks, are you seeking help? And again, I guess the good news is we don't seek help any more or any less than the rest of the country, but you can also see that it's only about 15%, which I suppose is consistent with the number of calls that we get. So again, we've got work to do here, but participating in this study sort of gave us access to data that we had not had before. So bringing this to a close, physicians who care for themselves do a better job of caring for others. We're less likely to make errors or to leave the profession. The habits of practice to promote well-being and resilience need to be cultivated across the continuum, and a healthy learning environment will lead to improved healthcare for all, for us and our patients. And we want to try to cultivate the positive. People who feel good tend to function well. A little bit, I'm telling you guys stuff that you know, but it's news a little bit to others outside of psychiatry. Promotion of mental health reduces the risk of mental illness, but we have to be proactive. We have to keep people looking upstream. The goal is to flourish. It is not just to make it through. Residency can be a, residency can be a very, very exciting time where the learning curve is so steep. And as Lottie Derby says, you have to try to arrange to have your peak experiences, those moments where you just feel in awe and at peace and excited for what's ahead. So if I could put it in pictures, internship sort of starts like this. You're kind of at the top of a mountain looking out on this beautiful, vast expanse. And for some, internship becomes a little bit more like this. You kind of fall down the mountain, you kind of get bumped and bruised and need a little bit of care. And while there are significant barriers that we need to address, it does seem that if we build a mental health service, we can get residents to take advantage of it and then try to make a difference. There are lots and lots of people to thank. Brett, who's running the service with me now, Brett Blatter, who used to run it, Ben McCommon, who ran it, Dave Kahn, who basically got me involved in this, Scott Goldsmith, who used to run this service at Cornell, all the people who are my supports, the eating disorder group, a big shout out to Mike Devlin, who always seems to have time when I walk in and go, Mike, wait, I just saw a resident, you gotta hear about this, or can you talk me through this, or what do I do? Mike is the quiet, unsung hero and really my supervisor in this. And really, I have to thank all the clinicians who have accepted referrals. Sometimes you didn't make me beg too much. And actually, to all the residents and fellows who have used the service, because that's why we do this. Thank you.
Laurel, really, thank you. That was incredibly interesting, informative, and a little bit sobering. I have the perfect sort of coda for your service from the New Testament. Physician, heal thyself. But let me start off with kind of a lightning round because it raised a lot of questions in my mind. So burnout, I mean, why do we use burnout? I mean, isn't that kind of a euphemism to kind of avoid more clinical precision?
So that's a great question to start with, and I'm happy to sort of put it out to the audience. I think what burnout allows us to do, and there's some advantages to talking about burnout, is it allows us to look at the institutional environment. It's not just a failing of the person. You have burnout and you have to fix yourself. It's that burnout, because its definition is a work-related syndrome, forces us to look at other aspects of the work environment to see if we can alleviate someone's distress.
I don't have any problem with that, but the other thing is, why not, and I know this is like a resource issue, but why not have, offer some type of service to everybody? Some people won't need it or want it. Other people will make sparing use of it. But it's not like they have to come forward and reach some threshold and go through a decision-making process. It's just automatically part of the training experience.
So as burnout and depression have become more, people have become increasingly aware of it, people have recommended a similar suggestion, which is, why don't we have psychiatrists or mental health people evaluate all the residents? At the beginning of the year, they should just evaluate everybody. Then they'll get to know them. You can do an assessment. And then if they need you, there'll be a personal connection. It certainly would keep psychiatrists in business if we had to evaluate all 900 people, who, residents and fellows who worked here. But I think the downside of that is a lot of people do just fine. If the depression rates are 25 to 30%, it means 70 to 75% of the residents are not depressed. And so I'm not quite sure that the benefit of evaluating everybody is cost-effective or even necessary.
Well, I didn't say evaluation, but that wouldn't be a bad idea, except that it has some pejorative aspects to it. But if you think of it as basically providing a resource to people, which has a potential preventative effect. The other thing is that, the financial barriers. So all Columbia employees have United Health. So
Right.
I see Lou Batista is left. So, we have a problem, or Ravi can speak to this. We have a problem. The managed care contracts don't allow for a financially viable service to be provided. So we take a loss in order to be able to serve certain employee groups like Columbia faculty and staff. Hospital doesn't have United Health?
Hospital does not have United Health.
So we don't have a contract, Ravi?
Yeah, thanks for bringing this up. So nearly all of our faculty practice now accepts the Columbia University employee plan, and we are having a growing number of people taking the New York Presbyterian plans. We have, I think, 3 psychiatrists now, a 4th adding in July, and new psychologists as well who will be taking the New York Presbyterian plan. And I'm currently treating 2 residents using it now. We're growing in that way.
It's really a step in the right direction, I think, and it just happened this year, which is really terrific that we can now take care of the residents that we have. But I will say, and this is with all due respect for Ravi's clinical skill and expertise, the clinicians who take the hospital insurance mostly are junior people. And so, while again, for many people, that's fine, and Ravi is treating a couple of residents, which is terrific. It doesn't work for all, and so we still have to think about other ways to accommodate, I think, some of the cost issues.
Well, for everybody over 50, we'll be taking volunteers at the end of the talk. Last thing, so the Nietzsche quote, that which doesn't kill you makes you stronger. So if the old timers will say, I went through it, why can't everyone else go through it? Are things different now, or are we just more attentive to the things that previous generations endured and to their disadvantage?
Sorry, I'm trying to find a photo here. So a little bit. The National Academy of Medicine is doing a little bit of a cognitive reappraisal campaign, if you will, that, as you're describing, this is the way many of us trained, right? I have to stay strong, suck it up, do it. I have to I have to take care of my patients. I can't afford to be tired or in any other way compromised. And so some of that, though, leads to this, which is a very popular image of an ER physician who just couldn't take it anymore. I think that there is a lot, I think suck it up and do it works, but I also think that times are changing and we don't have to have that as our driving motto anymore. And that culture change is being met with a little bit of, turbulence. But yeah, it works. We did it. Here we are. But can we do better?
I have one other comment, but I'm going to save it to the end because it's going to be very caustic. Speaking of the voice of experience, Dr. Wharton.
Oh, yes, one of the things, the first study that I'm aware of in the mental health of medical students was University of Pennsylvania. And I forgot the name of the guy who wrote the paper, but even in the 30s, the 1930s, the percentage of psychiatric consultations was over 35% in the 30s. But the other question I had, and Dr. Vagelos was concerned about this, the amount of debt that students have, some college debt, and the cost of medical education. Dr. Vagelos is hoping that he can get it so anybody who gets into medical school will not have any debt on graduation. You had mentioned debt as a concern, and then it can force the choice of subspecialty or specialty. So I wonder if it might be of interest to check about financial issues, particularly many medical students are married, have families, and so there are economic consequences in medicine. They say that if you became a UPS truck driver over the course of a lifetime, you'd do better.
Financially, you do better?
Financially, yes. Financially. In terms of the life of a doctor. In terms of what the unions get, plus benefits, plus retirement. So I wonder do you have any data on who have financial concerns? Don't ask the question.
No, there is not a lot of data, but certainly financial pressures are a source of stress, which will contribute to the stresses and then at some point overwhelm someone's ability to cope. I I don't have any particular studies to cite, but certainly financial pressures increase risk.
I think it's a good point, because in terms of whether there's generational effects, there are certain secular factors that pertain to the training experience now that are different than they were earlier. Some better, some worse, and certainly financial debt is one of them. Steve.
Thank you. Thanks for a great talk. It's really important. And I worked for years with medical students at a different institution. It's all true. The statistic of 400 suicides a year, that's like 2 or 3 classes, graduating classes of medical students. I think you've hit most of the bases, except there was a remarkable lack of talking about drug and alcohol use. I don't believe you even mentioned the word drug and alcohol once. And in all the experience I've had with med students, not in student mental health service, but in teaching med students, that has come up over and over and over again. It's true of all young people, but it certainly was true there. And I've had more people coming in getting drunk on harmless drugs like marijuana, and it's been a huge problem. There's always been a kind of antipathy between psychiatry and, say, 12-step programs, or the ability to recognize this. So anyway, I'm not criticizing or anything like that, but it's a concern about how do you incorporate this concern into this problem.
No, it's a really good point, and I have a couple of comments. Some of this is when I speak to the anesthesia department, I have a lot in there, a lot of slides in there. And one of my fascinated by a paper where the title of the article was, Can anesthesia residents who have been out on leave due to substance abuse be re-entered into residency? Like that's pretty specific. So they deal with it a lot, and I didn't mean to minimize it as an issue. And certainly alcohol use and other disinhibiting drugs raise the risk for suicide attempts in addition to the other risk factors. But what I will also say, and it's probably why I didn't mention it as much, in the house staff that I've seen and that Brett has taken care of, it hasn't been as big a problem as I thought. Now, I don't know whether that means it gets handled separately and whether the Committee on Physicians' Health and sort of the state systems and services that are in place to deal with the impaired physician, everybody just accesses so they don't need us to facilitate treatment. But I'm surprised, and don't really want to talk about it because I don't really want it to change too much, that the residents we see, it's not as big of a problem as I expected it to be, and probably as big of a problem as I expect that it actually is.
Matt.
Uh-oh, I'm in trouble.
Thanks, Laurel, for doing this grand rounds. I have a comment and a question. First, I just want to give a shout out. So I'm fortunate to get to sit on the APA work group for psychiatrist well-being and burnout. And this is chaired by Rick Summers. One of the things that we've piloted is putting out basically like a survey questionnaire for people in our field to respond to. It includes questions on burnout, but also some demographic information, an anonymous survey. But really the goal is to sort of characterize what's happening in our workforce. And so I encourage anyone here to go yourself and also spread the word. The URL is psychiatry.org/burnout, and you'll be able to find the link to that survey, as well as some toolkit resources that we've helped develop, including some of the materials that were presented here today. In terms of a question, so you mentioned the result that that resident age physicians do not have higher rates of suicide than the general population. But we know that there is a higher overall rate of suicide among physicians, and we've both seen that graph where it's really with people at older ages and middle-aged physician population that is at higher rates of suicide than the general population. So I think when we see things like this, often people are sort of motivated into action. And so what might you suggest to this crowd of psychiatrists would be ways for us to think about doing something or engaging, or as mental health specialists, being able to reach out to our physician colleagues beyond those who are in their residency years where they can access a service like yours?
Yeah, that's a great question. Advocacy is usually what you answer, but I think, partly what I hope is that this talk was kind of boring and not so new to you, because we deal in this every day. This is our job. And so we know about treatments, we know about taking care of ourselves, we know about promoting our well-being, but I think that our non-mental health colleagues don't. And so reaching out, being available, getting involved in the interventions that they are developing, I think can actually be helpful. And I think some of this has to be, some of it has to be stigma reduction, so that they don't get freaked out when there's a psychiatrist involved, but that they actually request that the psychiatrist be involved. And I will give a shout out to medicine for that. Medicine is probably going to start some process groups for their residents in this coming year. And they, the residents have had a history of some paranoia that if anybody from outside their department, and specifically psychiatry, knows about whatever's going on in them, that like they're finished, and they've really sort of kept people out. But their leadership and their program directors know about the rates of depression, the rates of burnout, and they actually want to facilitate the contact that medicine has with psychiatry to facilitate people who need help getting themselves to treatment, or at least trying to make that a little bit more likely. So I think getting on all the committees and the work groups and giving the talks and educating and running groups and sort of showing that we know how to treat depression, thinking about what the difference is between burnout and depression. There are likely treatments that we have for depression that'll work for burnout that we can offer. And, you know, writing and getting it out there is a great way to start.
Jay, then David.
Hey, Laurel, great talk. So just on that very topic you just mentioned, the links between burnout and depression, it really does seem, yes, syndromally there's some overlap, but you know, I've been learning more about these ideas of links, the mediator type analyses. You know, is there any progress to be made there, understanding what are the common traits or characteristics or events that cause the transition from just a burnout type syndrome to, you know, more syndromal depression?
So you just said that causes the transition. We don't even know what the relationship is. We don't know if it's on a continuum. We don't know if they're they're overlapping, but are they separate and distinct? I think there's a lot of work to try to figure out the relationship between burnout and depression. I personally think it's more on a spectrum, and that those that meet for severe burnout by whatever measure you use also actually meet for depression. So it's unlikely that you have two things, but more that you have one. But I think that, oh no, we could talk about that. But I think there's a lot of work to be done there.
Yeah, because it just would give you then maybe a handle in terms of, you know, how to prevent the transition. If you could identify it earlier, we always are talking about that. Mm-hmm. And then also, how the heck do dermatologists have like the second highest rate of burnout? That makes no sense to me.
I don't know. You have to ask them.
Okay, I'm going to put that question to David Bickers, and just as a follow-up to what Jay was saying, you know, if you look at the military, a combat experience, which David has had direct experience observing, you put people into some, you know, theater of combat, and individuals, some proportion of individuals will, you know, experience clinical symptoms in response to the stress that they incur, the psychological challenges. Some number of those who may have predispositions or otherwise will develop definable psychiatric disorders that occur. So in that context, when people are coming in, and I'm not suggesting everybody be screened for mental illness on residency interviews, but when people do come in, and even though there is a stigma, you know, if you have hypertension, you have a heart defect, you're going to have a baby, and you're going to on maternity leave, you know, there's no hesitation. But if you do have a prior history, it would be useful to make that known, and would be useful to be able to provide some kind of support going forward. So in terms of Jay's question, when's the transition? The transition is experiencing the stress that's, has a detrimental effect on everybody versus it's a precipitant to a, clinically syndromal vulnerability.
Yeah, I would say, and I didn't put it up there, I don't think we know a lot about who's vulnerable to developing burnout and depression. Again, Sreejan has some data. We know that single people are more likely to be depressed than married people. We know that interns who are more dissatisfied with their clinical faculty are more likely to experience depression than those who are more satisfied with their clinical faculty.
If somebody has a prior history.
So does prior history make a difference?
You have a prior history, you may be treated, or you had achieved remission and you've discontinued after sufficient continuation treatment, but you're going to go into postgraduate training. So Barbara, can you predict, who might be most vulnerable? Or it's just so imprecise and non-specific that it would be, the number needed to identify would be, would not justify it.
Geez, I was out late last night. I was napping. But I think that your point about relating it to the military, I think is very apt, because there's a lot of research that looks at who is it that becomes suicidal in the military, who develops PTSD. And there's a decent body of evidence that says whatever happened beforehand, whatever makes you vulnerable beforehand, makes you vulnerable in the military, in combat, for example.
I guess what I say, and I'll let you talk. There's a lot more that could be done, but at the risk of maybe stigmatization and some kind of pejorative consequences.
I think it's very complicated, and we would be wise, I think, to sort of pay some attention to this about the impact of prior mental health history on your ability to successfully finish residency. For now, we're
It's not a matter of finish. It's a matter of would you benefit for some kind of prophylactic support?
Well, so certainly if you've had a history or you're in treatment, you should continue in treatment. And as I was talking to the interns, the psych interns the other day, actually, if you report on your employee application for NYP that you are on meds or you are in treatment, that gets flagged. But it's not a red flag. It's they bring you into workforce health and safety, and they say, I see that you've had a history. I see that you reported this. Do you need help with referrals? We want to make sure you're plugged in. Internship is a stressful time, and you might want to make sure that you are connected, and then they will make those referrals. But I don't know. In psychiatry, evaluating someone for their previous mental health history and then deciding whether they should or shouldn't be a resident or whether they are more or less vulnerable than anybody else, I think that's dangerous territory.
So one of the things I was thinking about when you had that intern on the cliff there looking at the vast expanse, I was wondering if kind of like thinking about this in a flip way, thinking about helping people readjust expectations. Yeah, there's a vast expanse, but it's this, and what can you do to protect yourself? And so does that happen? Like resetting, like this is going to be really hard. You have been perfect all along. You're not going to be perfect anymore. I mean, I think that triad was really good. That's who I have seen. Perfect people up to this point when they can no longer be perfect.
Yeah, I think it's a really good point, and I think that we probably could do better to help people moderate their expectations. I guess what it makes me think of, and I didn't show these slides, is Sreejan Sen did a study where he randomized incoming interns either to 4 weeks of online CBT or psychoeducation. And the psychoeducation was internship's going to be challenging, here are things you might experience, and the online CBT was more cognitive reappraisal and techniques that CBT used. And they then did his intern health study, and they followed them quarterly over the year. And there was a big difference in the self-reported suicidal ideation, whereas those that had gotten the psychoeducation reported sort of 21% suicide, 21% had reported suicidal ideation, whereas those that got the web CBT was about 11%. So there's something to telling people what it's going to be like, and there's a little bit of, I think that's what I do at orientation, like, let's adjust a little bit, this is going to be hard, but here's what might be able to help. But I think we need to do better than psychoeducation. And again, you were asking where can psychiatrists come in? They can come in, mental health people can come in there, because CBT, that's what we do, and it's seems to be very effective.
David?
So this is a very helpful overall approach, and largely epidemiological, right? That you're looking at this from the externals. By the way, in regard to that, I get all these. I practice downtown, so I get all these house staff and doctors from other medical centers. So I think your numbers must be very low, because I know that they don't tell anybody that they are coming to somebody privately, But aside from that, I wonder, to amplify this, if there could be something like Matthew's grid of all the things that could be done, if there could be some kind of a grid that would be helpful, where you talk about traits and things that are more intrapsychic that house staff might have that they could fall into. For example, getting much more self-involved rather than other-directed. The problem's not about you; it's about the patient. Alexithymia would be an example. In not recognizing emotion in yourself or in others.
You're going to have trouble selling that to the surgeons.
Yeah, well, yeah, they're blind. Well, no, some of them are good at it, actually. So I think it strikes randomly across the...
I don't mean they suffer from it, but having that kind of a value.
Yeah. But I mean, intrapsychically, so that people could start to think about them, if they want to think about themselves, at least think about, look, am I getting too self-involved here, or what is it about me? I could start to think, what is the Boy Scout oath of being a house staff, and so on. And I'd
Laurel's job is hard enough.
A big grid about that.
Without introducing I think that dimension will. Well, you answer.
Go ahead.
No, I think it's really, I think it's important. I think it's interesting. I think different specialties have different abilities to observe and reflect. I do think helping people to observe and reflect is useful. I think that there also does need to be the balance. The residents are already vulnerable to "it's all my fault. I can't handle this, I'm weak, I can't do it." So things that then tend to sort of get them to, what am I doing wrong? We've got to help shift that.
Yeah, I agree. That's a trait, though, of being overly internalized, not realizing that they have to focus on the patient. It's the patient's problem, and you know what I mean? They're taking it on.
Yeah, what I was going to say for the surgeons, actually, the surgery residents this year have started a Ballant group. So they're doing groups, but they're not interested in just talking, but they do it around a patient case. But it's not the details of the actual management of the case, it's the relationships that get triggered and the difficulties that they have in the relationships in taking care of the patient. And that they seem, I'm doing some with the anesthesia groups, somehow talking about a case allows them actually to access feelings and responses that they then find very useful, even though you've sort of, sidetracked them into it.
Yeah, that sounds like a great therapeutic vehicle. We're running out of time, so
Just
last
quickly,
question,
Laurel,
Evelyn.
terrific talk. I have a question about non-MD clinicians for helping physicians in training. So it relates a little bit to these specialty differences and culture differences, and I know you've got some strong beliefs and have really tried to pair physicians with physician clinicians, but we're in a world where our work is done across a whole range of disciplines. Do we have any data about how physicians fare when referred across different kinds of mental health clinicians?
That's actually an interesting question. Do we have any data about how they fare? No, I don't think so. I don't think so. I do have strong ideas and beliefs about it, but they're just my own. They're not really based on.
But do you mean that they would feel it was demeaning to be treated by somebody who wasn't at the same academic?
I
or
know the House Staff
medical
Service relies primarily on physician clinicians, and some of that may be belief, that some of that may be the feedback you get. I'm not sure, but I wonder what our capacity is and whether.
Right. So some of my perspective on this comes from, fairly or unfairly, that internship and residency is a unique experience. And having gone through it, you understand it in a way that people who have not gone through it don't understand it. And there have been, again, anecdotes, a case here or there, where a resident was treated by a psychologist who said, you really need to protect your sleep. You just have to tell your chief that you have to sleep 8 hours a night and you simply can't take call. And you're like, that's not particular, so, and I don't think a psychiatrist has, having gone through it, would ever say that. Now, does that mean that there aren't excellent psychologists who can understand? And certainly, as psychiatrists, we don't need to experience everything that our patients experience to be able to take care of them. But I still value, I think of it a little bit as sort of a professional courtesy, which I also know is sort of going out the window. But it's a little bit of an opportunity to understand and to give back to our younger colleagues. But that's not to say that other mental health professionals can't also do the therapy that's involved.
It shouldn't even have to be a give back. There should be insurance benefits that that are at least reasonable. So my concluding, is it quick?
Thanks, Laurel. I just wanted to give a shout out to actually working with these patients. And my perspective, thinking about the Grey's Anatomy thing, is that, there's an awful lot of identification with the aggressor over time in medicine. I was made to do this, so you're going to be made to do this. And a lot of sense of fear that you're not measuring up to these sort of giants of the past. And, I just wondered if you had tried things like pairing residents with people right above them to start to create a chain of people that are supportive, as opposed to, well, I did this, so you should do this. Because it strikes me that kind of identificatory, like, now it's my turn to put my thumb on the intern, is part of the problem of the culture.
Yeah, it's a really good point. And I think that my thought to that is this requires multiple perspectives. It requires residents to be supported by other residents. It requires junior faculty and senior faculty to be informed by junior residents, and so that from the multiple perspectives of how things can go, I think that's how we move it forward. I think that to change the culture, you need people who don't think that the way you have to do this is by sacrificing everything. And then it's to help the faculty grapple with, you mean there was a more humane way to have gone through what I went through? So I think that the mentorship and the interactions come really at the multiple levels, and it's not just one to the other.
Well, we're really glad and proud of you for doing this, and thanks for sharing the experience.
Thank you. Thanks for the opportunity.